stroke. How will you suspect, or when will you suspect hemorrhagic stroke? Patient will have increased intracranial pressure. There's blood accumulating in the brain somewhere, right? Patient will be vomiting, headache, right? Papilledema. Check the retina, it's swollen, papilledema. Patient will be confused, disoriented. They can have like seizure as well. Yes, seizure. And if you're given imaging CT MRI, you're going to see blood, right? Either in the brain is a white density, right? In the brain itself or somewhere in the subarachnoid space, something like that. So you're dealing, okay, it's an hemorrhagic stroke. It's a hemorrhagic stroke rather. Forget ischemic, focus on what? Hemorrhagic. You can further divide hemorrhagic based on the location into what? Into intraparenchymal, if the bleed is within the brain, substance of the brain itself, or if it's within the subarachnoid space. This is the space surrounding the brain, right, where we have our CSF and stuff accumulating. In intraparenchymal stroke, I can further divide it further, right, into if it's a deep structure stroke. Is the hemorrhage in the deep structures where you find the internal capsule, right, and the thalamus. Yeah. So those are people that also have what? Focal deficit, pure sensory stroke, pure motor stroke. There is no cortical dysfunction. No cortical dysfunction, no cranial nerve, right? Defect. So you think, okay, this is a deep brain structure stroke. The mechanism of deep brain stroke or internal capsule hemorrhagic stroke, thalamic hemorrhagic stroke, it is right, will be ruptured, Charcot, Bouchard aneurysm of the lenticular striatal artery, right? So in this case, instead of the lenticular striatal artery being occluded by hyaline atherosclerosis, which is ischemia, they actually have aneurysm. The wall becomes weakened because of chronic uncontrolled hypertension and it's going to bulge out and form an aneurysm. We call that Charcot-Bouchard aneurysm. This, if this aneurysm ruptures, then there's going to be bleeding within the deep structures. That's why you're going to see the hemorrhage for that. If the bleed is outside deep structures, the lobe, frontal lobe, we're dealing with a frontal lobe, we're dealing with so we're dealing with frontal lobe, we're dealing with the occipital lobe, parietal lobe, right? You can see clearly lobar hemorrhage, which will be very, very large, not deep structures. Then this is commonly associated with amyloid angiopathy. These are people that have Alzheimer's disease, right? People with Alzheimer's disease or older patients, amyloid can deposit in the wall of the larger cerebral vessels and they become very, very weak. And they can rupture because of that. And this usually leads to a massive lobar hemorrhage. It's not the smaller ones like in the brainstem or the destruction. No, in the lobe itself, frontal lobe will all filled with blood. So if you see, either they give you a patient with Alzheimer's, with hemorrhagic stroke, which will be likely amyloid angiopathy, or a patient like this, they don't tell you the risk factor the patient has, but then they're telling you that the lobar is the hemorrhage involves the whole lobe of the brain, or they give you the image and you see white density involving the whole cerebral cortex lobe. It's going to be likely amyloid angiopathy. That patient has the vessels, the cerebral vessels are weakened by amyloid deposits in their wall, and they can rupture and lead to that massive lobar hemorrhage. These are the very, very poor prognosis, but these enough to test as well. So deep structures, hemorrhage, ruptured Charcot-Bouchard aneurysm. Lobar, amyloid angiopathy. Yeah, I'll probably also put brainstem here as well. So deep brain structures and brainstem, like pontine hemorrhage, medulla hemorrhage, hemorrhagic stroke, cerebellum, right? Cerebellum. Patient with chronic hypertension, if all those vessels that supply those locations, right, they have Charcot-Bouchard aneurysm, aneurysm can rupture and lead to hemorrhagic stroke of the brainstem, deep brain, cerebellum, and stuff. But if it's a lobar, it's likely going to be amyloid angiopathy, large Alzheimer's, old age would be your risk factor for that. If in subarachnoid hemorrhage is going to be ruptured berry aneurysm, right? So patient, I'm seeing bleed in the subarachnoid space. Remember the circle of Willis, it's in the subarachnoid space. Circle of Willis. Vertebral artery comes in, forms the basilar artery. Basilar artery continues as the PCA. Yeah. And PCA communicates with the MCA with the anterior communicating artery. ACA communicates with each other with the anterior cerebral artery. Posterior cerebral artery, communicating artery, right, connects. Yeah, PCA and all that. So basically, circle of Willis is right here, right? So I have my vertebra comes in. Cerebral comes in vertebra. PCA continues. Then you have MCA coming in this way. MCA going to communicate with PCA that way. And then we have ACA going anteriorly. And then they communicate somewhere there as well. So everything in blue is what? Is internal carotid artery. We call them anterior circulation. Everything in blue, they're coming from internal carotid artery. Everything in blue. And which includes the ACA, anterior cerebral, and the middle cerebral artery, MCA, in anterior circulation. They supply mostly this anterior part of the right brain, right? Frontal, parietal, temporal, right? Stuff like that. But then everything in green is what? Posterior circulation, which is coming from the vertebral artery. Vertebral becomes basilar, right? Basilar. And this will give rise to some other things here, like the right pica, which supplies the cerebellum, cerebellar distribution, then basilar pons, as well as part of the midbrain, and then PCA midbrain, and then goes all the way to the occipital, right? So posterior circulation. And this is important. Anatomically speaking, this is important, right? A patient with vertebral artery is coming from where? Vertebral artery is coming from subclavian, right? Vertebral artery is a branch of subclavian artery. So vertebral is coming from subclavian artery, give rise to vertebral arteries. Carotid, internal carotid is a branch of what? Brachiocephalic trunk, right? Coming directly from brachiocephalic trunk, and yeah, enters, right? Becomes internal carotid or common carotid, which become internal and external carotid, right? In patients with a pathology, right, affecting the vertebral artery, let's say somebody has vertebral artery dissection, for instance. Patient has what we call subclavian steal syndrome, right? Where there's occlusion, there's narrowing of the subclavian artery, right, proximally. So blood will be diverted from the vertebral artery into the upper extremity, right, when doing exercise and stuff like that. Those people, and also patients who also like migraine, there's a migraine with aura sometimes affects the posterior circulation. So these people usually have what they have posterior circulation stroke, not anterior. So if somebody is having vertebral dissection, maybe they injure their neck, vertebral, cervical vertebral fracture, things like that can affect the vertebral artery. There is a subclavian artery, maybe occlusion. There is subclavian steal syndrome. They are taking blood away, right? Or there is embolism through the subclavian artery, right, into the vertebral artery. Or there's an atheromatous plaque in the vertebral artery. Yeah, leading to thrombotic stroke. Or there's some hemorrhage going on here in the green circulation, posterior circulation. It's going to affect only what? The brainstem and the cerebellum and occipital lobe, maybe. Occipital lobe, brainstem, cerebellum. But the frontal lobe and parietal will be spared because they're supplied by MCA and ACA, anterior circulation. But if it's a pathology affecting the common carotid artery, internal carotid artery, it will affect what? Mostly the anterior circulation, right? The posterior circulation will be what? Will be spared in that case. So this answers questions like why will you see that differentiation in maybe presentation sometimes, depending on the location of the pathology or which artery is affected, because we have two circulations basically that are connected that supplies the brain and the brainstem and co. Anterior circulation from the carotid artery and the posterior circulation from the vertebral artery. They may be affected simultaneously or isolatedly. So the patient might have only anterior stroke without posterior circulation stroke, or they can have posterior circulation stroke without anterior, right, circulation stroke, right, depending on which artery, right, the pathology is. So this is going to be important. So in this, and where is the circle of Willis? It's in the subarachnoid space. So in patient with connective tissue disorders, patient with hypertension, polycontrolled hypertension, connective tissue disorder like Marfan, Ehlers-Danlos, autosomal dominant polycystic kidney disease, what happens? Aneurysm can form, right? Aneurysm can form. So aneurysm can form here, usually the posterior communicating artery, they can form because all these areas of bifurcation, right? Those are weak points. Aneurysm can form where basilar artery bifurcates. Aneurysm can form between the PCA and posterior communicating artery, right? Artery. Aneurysm can form somewhere here between where the ACA and the anterior communicating artery, right, comes up. Yeah. So those are common locations of what aneurysm in the circle of Willis. And there are nerves, right, that kind of run close to these areas of aneurysm. So for instance, the PCA aneurysm or posterior communicating artery aneurysm, this aneurysm here may affect or compress cranial 3. Yeah. This aneurysm here, the one here around ACA, anterior communicating artery, may compress the word optic chiasm. Yeah. So if a patient has, what's the headache of my life, which is how subarachnoid hemorrhage presents, sudden, severe headache, neck is nothing like they've ever experienced before in their life, and patients having neck stiffness, right? Because it's the meninges, it's going to be irritated, right? They have neck stiffness, they can have neck stiffness, they come with their neck problem. You think they have meningitis, but they don't. There's no fever and stuff. Yeah, neck stiffness, Brzezinski sign and panic might be positive in that patient. Sudden severe headache, right? Patient has maybe risk factors for subarachnoid hemorrhage, right, or intracranial aneurysm. And the examiner can ask you, of course, pathophysiology, right, first. Or risk factor. What's the risk factor? Okay, hypertension or polychondria. The patient is younger. There's evidence of Marfanoid habitus, Ehlers-Danlos, autosomal polycystic kidney disease. You pick whatever risk factor you see there. They can ask you why, what would be the pathogenesis? It has to do with rupture, right? Berry aneurysm, the cycle of Willis. Ruptured berry aneurysm. So the aneurysm, we call this aneurysm berry, not Charcot-Bouchard. Charcot-Bouchard are for what? Smaller arterioles, like lenticular striates, right? That supplies the deep structures or the brainstem or cerebellum. But for these larger arteries in the cycle of Willis, we call them berry aneurysm. Yeah. So, and they occur at what areas of bifurcation, right? Where the thickness of the wall is decreased, or where the vessel was thinnest. They don't have the medial layer, right? So they're going to be at risk for aneurysm at that point. So if that is ruptures, or what's called circular aneurysm, right? Berry aneurysm, circular aneurysm, that's another name you might hear me involved, right? If the rupture, that leads to subarachnoid, right? Hemorrhage, for sure. And the examiner can also ask you location. The most common site of berry aneurysm formation or circular aneurysm formation in circle would be what? Would be the posterior communicating artery, right? PCA junction. PCA, posterior communicating artery junction, that would be the most common, right? Followed by, I think, ACA, yeah, junction. ACA and anterior communicating artery junction. Then the area of bifurcation of the basilar artery, right? That's also a common location, but the number one would be this site here. Yeah, posterior communicating artery, PCA, right? Communication, yeah, junction. And if a patient has aneurysm here, which nerve is at risk of being compressed? That's another neuroanatomical question. Cranial 3. Or I suspect somebody has subarachnoid berry aneurysm in the circle of Willis, and patient also has cranial 3 palsy. That gives me an idea, right, of the location of the aneurysm. Oh, patient has ACA or anterior communicating artery aneurysm, which structure is at risk of being compressed, maybe what optic chiasm. So you might see bitemporal hemianopsia as well, right, in that patient. So, or binasal hemianopsia, something affecting the chiasm. Yeah, depending on which side. So those are going to be things that are testable with these, as well as understanding the rationale right behind their presentation or what structures can be affected. So that's the part of physiology.